Good morning, Dr. Cantor.
Good morning. Can you hear me?
Yes.
Yeah.
Great. Okay. We're a couple of minutes before the hour. Maybe we should see who else joins. You want to give it a minute?
Viva, do you have our slides or my slides?
Yes, I have
All
your
right.
slides and
All right.
Dr. Binghamton's slides as well.
Okay.
So I will drive them when you present.
Rick, is that Charles Darwin behind you, or?
It is, and it's a work of art that I bought in Kansas City by a local artist, and it's made out of computer keys, black, white, and gray computer keys. So when you get up close, you can't tell who it is, but when you stand back and you see it in a video or a photograph, it looks like a painting. So it's a great piece of art sculpture.
Yeah, yeah. All right, and I see the Golden Gate Bridge behind Carrie.
It's just the Zoom comes with it, but it is right outside. So.
Yeah. All right. Well, we'll give it another minute here. I see Hayo. What's the painting behind you?
Well, it's Alexander von Humboldt behind
Oh,
me.
yeah, of course. Yeah.
One of the large explorers from Germany.
Yep, yep, yep.
So he's looking at me in my office all day.
Keeping an eye on things.
Yeah, yeah.
Well, let's see. Habiba, are we expecting a couple of more folks?
Yes, we're just waiting for Dr. Pignatelli and Professor Luciano Sasso and Dr. Ponikvar from Ljubljana.
Yep, yep.
Can you send us the list of everyone who's invited or will attend? Because all I have is the speakers.
Yes, absolutely. I will send it to everyone.
Let's see. I see Christoph from Salzburg and
Richard Greil, Salzburg.
yes, yes. All right, we'll go around in a minute. All right, well, it's just after the hour, so I will go ahead and get started and welcome the other folks when they join us. Let me say just a couple of quick things here. You know, first of all, I understand how busy everyone is and how everyone is rapidly adapting to change. And so we appreciate you taking time to be with us today. And in a minute, we'll ask each person to introduce themselves so we can make sure we all get to know each other. And since we have a few people who are new to AAHCI, I just wanted to say a couple of words about our international division. You know, we hold a number of different kinds of meetings. Recently, our Southeast Asia office held a webinar. I think maybe Albert was involved. It drew over 400 attendees. And we hosted another webinar with our Latin America regional office, and there were over 100 attendees. So we hold those larger webinars, but we also hold regional meetings like this one, small, intimate, an opportunity to get to know other top leaders around the world and to share real problems with trusted colleagues. And that is consistently one of the things that our members tell us they like the best about AAHC is these smaller opportunities to really get to know some other top leaders and have some genuine conversations. And, you know, we all share the same problems, but we bring different perspectives to the table, and that adds real breadth and depth to our ability to think about those problems and to develop solutions that work at our own institution. So let me stop there and let me go around and ask. I should have said at the beginning, but I think I know almost everybody. I'm Stephen Cantor, President and CEO of AAHC, the Association of Academic Health Centers and the International Division. So, all right, so let's go around and ask people to introduce themselves. And then after that, I think Hayo wanted to say a few words, and then we'll proceed from there. So let's see. Hayo, you want to introduce yourself to get started?
Yeah, I'm Hayo Krömer. I'm a pharmacologist by background, and I'm CEO of the Charité hospital in Berlin since September of last year.
All right, great. Thank you. Carrie, you want to introduce yourself?
Sure. I'm Carrie Byington. I'm the Executive Vice President for the University of California Health System, and I'm a pediatric infectious disease physician.
Great. And you were previously in Temple, Texas, or College Station, or both. And I will tell you that my son was born at Scott and White Hospital. So,
oh, congratulations.
We can talk more. Well, that was 30-some years ago, but we'll talk more about that at some point.
Another
all right. Rick?
Hi, Steve. Good to see you. I'm Rick Barron, and I am in Columbia, Missouri, which is in the middle of Missouri between Kansas City and St. Louis, where it's the flagship University of Missouri campus. And I've been here just 6 weeks as the Executive Vice Chancellor for Health Affairs. And Steve and I knew each other from Kansas City days when he was the dean at University of Missouri, Kansas City, and I was at University of Kansas.
Right, and most importantly, you worked with my sister, so you really know
That's
about
true.
it.
That's
Yeah.
true. Yeah, your sister and I worked together in San Antonio when we were first starting. Yes.
Yeah. All right, Albert.
Yeah, I'm Albert Scherbier, please call me Albert, that's easier. I was dean till June 1 from the Faculty of Health, Medicine and Life Sciences in Maastricht.
All right, great. And Richard.
Yes, I'm Richard Greil, and I'm the head of the third medical department at the Paracelsus University Salzburg. I'm a hematologist and oncologist, but also board certified for infectious disease. And I was the lead person for the crisis team for the state of Salzburg.
All right, thank you. All right, Chris.
Hello, everybody. I'm Chris Smith. I'm the Director of Member Programs at AAHC and AHCI.
All right, Elizabeth.
Hi, everyone. I know many of you, but it's nice to see some new folks as well. I'm the Chief Operating Officer at AAHC and AHCI.
All right, Habiba.
Hi, everyone. I'm Habiba Osmani, and I'm the Program Coordinator at AAHCI.
All right, and Professor Olga Lefkovich. Good morning, or good day, I should say.
Well, actually here it's good evening. Hello, everyone. I'm an executive director of the School of Medicine of Nazarbayev University. It's in Kazakhstan, in Nur-Sultan. I'm glad to see you all, and I'm deeply apologize. I lack a webcam on my laptop, so unfortunately you cannot see me.
All right, thank you. Welcome. Christoph.
Hi, can you all see me now? Oh, just a second. Hi.
No.
Hi. My name is Christoph. I'm working in the rector's office here in Salzburg at Paracelsus University, and we will organize next year a symposium which will deal with the whole pandemic COVID-19 thing. So have a nice day.
All right, thank you. Christoph worked closely with Chris to put on a great meeting in Salzburg a year ago. And in fact, it was so good, we made the front page of the Salzburg newspaper the following day, right? So had a great meeting. Okay, let's see. I think I've got Did I miss anybody? No. Hayo, you want to say a few words?
Well, as I understood, I was supposed to say a few words on what happened in Germany during the last 2 or 3 months. Just give you a minimal intro in the place where I'm working, which is Charité at Berlin, which is one of the really large academic medical centers in Europe. We have about 19,000 people working with us. We run 3 large hospitals with a total of 3,000 beds, and our annual turnover is around 2.0 billion euro last year. We see about 154,000 inpatients per year and have about 8,000 students with us. So it's a rather large place. And we were hit in March by COVID-19. And as you have heard, the Federal Republic of Germany from the government had a rather tough action. Mid of March, in essence, the entire country was closed. And our owner, which is the city of Berlin, told us to stop everything, which is reasonable in medical terms, which has nothing to do with COVID-19. So we should really concentrate on COVID-19, which we did within a couple of days. And so for something like 8 weeks or so, we had half of our beds empty and really concentrated on COVID-19 patients. And overall, just to give you the figure from this morning, Germany has a population of about 80 million people. And this morning we had 191,000 people infected and 8,897 people deceased. So if you put that into an international comparison, this lockdown and the concentration of the hospitals has overall worked okay. In Berlin, we had a massive increase in our ICU beds. We had already lots of them, for example, if you compare it to the Netherlands or other countries, which has something to do with our reimbursement system, because for the last decade, it was quite profitable to have ICUs. And it was not long-term planning, but that was the real reason why Germany was quite well off in terms of available ICUs. And the other thing, what happened in Berlin was that they really concentrated. We're an area of about 4 million people, and the really sick COVID-19 patients were concentrated to our hospital. That was point one. And the other thing, overall, the area of Berlin has 1,100 ICU beds, and they were all organized by a physician from our institution. So regardless who owned this bed, the guy in our place, this physician, he could decide which patient should go in which bed. So at the end of the day, it was quite well organized, and we had something like 350 really sick people with us. And just to give you an idea, we had a death rate with 44 people dying. So the percentage, again, in an international comparison, in view of the disease state of these patients, was okay. So I think the story in Germany was concentrating very sick patients to specialized hospitals. In parallel, we have done a lot in terms of testing, because after a couple of days, we were able to do 5,000 tests per day. For that, we were able to screen first parts of the Berlin population. And then we were able to screen 12,000 of our 19,000 people working with us. And we found about 0.5% being infected and about 1% having antibodies. So very, very low percentage. It's one of our largest day-to-day concern to keep COVID out of our hospital. We've created an own COVID app where you can check whether you're at risk and whether you should be tested, which kind of reduced the amount of people coming to us for these individual COVID tests. And one thing I really wanted to mention in this special round is that the Federal Republic of Germany decided to fight COVID in particular with the academic medical centers. And for that, they gave 150 million euro to Charité to create the network of German academic medical centers in fighting COVID. And so we are in the process to do that. Currently, all 35 academic medical centers in Germany have agreed to contribute to this network. So we exchange in terms of patient care. We create databases where everybody contributes and everybody can get data out. So when the next wave comes, which we kind of expect for later this year, the academic medical centers will be the first line defendants in this network to fight COVID when, as I said, when the second wave comes. So we are still very alert, very careful, but I guess so far, and I'm really, I'm rather hesitant to say that because nothing is over yet. So far, the crisis has been dealt with okay in terms of medicine. There are other things like social aspects, like economic aspects, which are not topic of discussion today, which will give us large problems in our country. But on the medical side, so far, the entire thing worked okay. Thank you for listening.
Thank you, Hayo. It sounds like Germany had a fairly solid, organized response, which obviously makes a big difference. Let's see, next on the agenda is Carrie Byington. Carrie, you want to talk a little bit about that?
Sure. I think Habiba has some slides that she could share. And I'll go through them quickly. I am struck by Hayo's presentation of how similar Germany and California have been. So it's interesting. So for those of you who are not familiar with the University of California health system, it's the largest academic health system in the United States. We have 6 academic health centers that include 12 hospitals, not quite yet, please, across the state of California, and 19 health professional schools, including medicine, nursing, public health, dentistry, pharmacy, veterinary medicine, and optometry. We are the only public health system in the state of California. Next slide, please. There we go. You can see where we're located across the state of California. The color codes are the patients that we serve in each region for each hospital. Last year, we had almost 8 million outpatient visits, 1.1 million inpatient days, and 1.8 million unique patients. And each of these facilities is a very well-run operation. All of them are in the top 10 for quality in the state of California, and UCLA and UCSF are nationally ranked in the United States. We operate as a system, but again, each hospital is used to maintaining their own operations. Next slide, please. So at the time of COVID-19, we all face the same challenges. Each of the academic health systems have their own policies and procedures. They were used to working independently. We were going through enormous change. California had some of the very first cases of COVID-19 in the United States, and there was an urgent need to work in a coordinated manner, and individuals at the hospitals, the vice chancellors for health, the CEOs of the hospital, recognized that we were having to make decisions quickly, and it was important that these decisions were aligned. We also are part of the University of California education system, and President Napolitano tasked me to oversee the safety of the 300,000 students and the 270,000 employees, so almost 600,000 individuals who are part of the education enterprise of the campus. Next slide, please. And I did not mention that I arrived at the University of California to lead the health system on October 31st of 2019. And December the 31st of 2019 was the first day that I heard the word novel coronavirus, and it just moved very quickly from then. So on New Year's Day, I called the president and asked her what emergency management there might be at the University of California, as I was concerned about this emerging infection. And you all may know that the president of the University of California system is Janet Napolitano, who led Homeland Security in the past. So we had, actually, I was able to see that we had a phenomenal management response team across the university to manage emergencies. However, they were used to managing short-term emergencies like a fire or an earthquake that happened in at a single site and was resolved within a period of days to weeks. They had not been used to managing something as large as a pandemic that involved every site and clearly is going to take months to years. And so I set up and I asked to start a new committee, the UC Health Coordination Committee for COVID-19, as a new management structure within this team. And that's what I'll just spend the next few minutes on. Next slide, please. So this coordination committee involved individuals from all of the campuses. It brought us together to interface with groups that already existed for the management of the health system, but we were able to develop new subject matter expert groups in bioethics, clinical trials, education, infectious diseases, laboratory medicine, public health, and telehealth. And just some of the things that this group did, for example, bioethics, we worked across the system to create the guidelines for crisis care and allocation of limited resources such as ventilators, remdesivir. They're now working on an allocation strategy for vaccines. We organized all clinical trials across the system, so we would review them centrally. We had a single IRB for all of the health centers, and individual health centers would decide to participate. So, for example, the remdesivir trials, we stood up remdesivir trials in all of our health centers within about 72 hours, and were major enrollers in the remdesivir trials that led to emergency use authorization. We did the same for convalescent plasma, and we now have about 40 different clinical trials that are ongoing. We coordinated all of the educational issues with our health professional students, their early licensure, graduation, testing, which was limited because of COVID. And we set the infectious disease policy for the entire system, how we would test, who we would test, our masking policies, our personal protective equipment policies, and infection prevention policies. Our laboratory medicine group set up testing. We lobbied the FDA. I think all of those who are in the United States know the testing difficulties we had early on. We were actively lobbying CDC and FDA to allow laboratory developed testing, and we were amongst the first labs in the country to set up testing. Our public health group focused on campus safety, and then telehealth. At the start of the pandemic, we had, as an institution, fewer than 1,000 telehealth visits a week. And today we have more than 60,000 telehealth visits going on each week to support chronic disease management, primary care, COVID patients. And we set up a telehealth critical care network that has served the state. Next slide, please. So these are just some of our dashboards. The color codes are each of the facilities, the test numbers that are done each day. Since March the 12th, we have performed over 100,000 tests for COVID-19 for our inpatients, and a similar number of tests for the public health laboratories across the state, nursing homes across the state, homeless shelters. We've taken on the public health testing for the state of California. Next slide, please. And each day our group meets. In the beginning, we were meeting twice per day. We have now changed that pace, and we meet every morning and 3 afternoons each week. We go over the census. We have dashboards that allow us to see every patient in the facility, every patient in ICU, every patient on a ventilator or ECMO. We also keep track of PPE, personal protective equipment, and the staffing. And we've been able to move equipment, personal protective gear, and even providers across the system as one place had more patients than another, and as we've gone through the epidemic. Next slide, please. Here's a PPE dashboard that allows us to see each type of personal protective equipment, our days on hand. We use a green, yellow, red stoplight mechanism, and then we model it out for 2 times the burn rate, 4 times the burn rate, 10 times the burn rate, to give us a feeling of how much personal protective equipment we have on hand. That's been incredibly important as we are now reopening our facilities. Just like Germany, we were under order to limit all but emergent and essential life-threatening procedures. So for a period of time, we had census of 40 to 50%. We're now opening up to other procedures, and being able to balance our personal protective equipment and staffing has been vital. And it was this coordination and also the strong work of the governor of California that led us to be in a very prepared state. By early April, we felt that we could handle what was coming, and it allowed us to send our personnel to New York City and to the Navajo Nation and to Tijuana at the border of Mexico and across the border to assist our colleagues and to help in the care of these facilities that were either experiencing surge or chronically have understaffing or other needs. Next slide, please. And so we feel very fortunate that we have been able to prepare our system. We've developed new tools that we will continue to use even after the pandemic to manage our care of patients. And we feel like we are ready to enter the next wave, and happy to share any information. So we also, I neglected to say, put all of our data online on social media. And so every day it's on Twitter, and we manage data for the state of California as well. So thanks very much.
Thank you, Carrie. That was great. Let's see, any questions for Carrie before we move on? Or comments?
Can I ask something, Stephen?
Yes, please.
Carrie, that was a very impressive thing, and there indeed are many parallels between Germany and California in this thing. Do you have the, are you officially the organization which does the testing for entire California? Because we've been asked by the government of Berlin to develop the test strategy for the entire area here now, and we took this responsibility, and it will be very, very interesting to exchange the experiences on whom to test if you go to schools, kindergartens, and all these type of things. I will be really interested to exchange the exchange the experiences on that.
Yes, we were not the official testing site for the state of California as the pandemic started, and the state of California has 9 public health laboratories that report data to the Centers for Disease Control federally, but they became quickly overwhelmed, and they did not have the capacity that the University of California system has. So the governor set up a testing task force and our laboratory directors, as well as laboratory directors from Stanford, University of Southern California, and others are on that task force. But we did take over testing for all 58 county health departments. So when they become overwhelmed, we get the test, or we just get the test anyway, even if they're not overwhelmed. And so we're working towards the fall as we need to balance testing between individuals who are sick or presenting symptoms, as well as asymptomatic individuals, as we try to open both the public schools and the universities. So we're in the midst of that right now, and I lead that testing and tracing task force.
Yeah. Other comments or questions?
The other thing I failed to mention is of the 100,000 that we've tested, we have almost 3,000 positive cases through the University of California system, and we have had 86 deaths so far in the University of California system. So I don't want to call it by any means a final death count because many of our patients are still hospitalized, but that's right at 3.1%, which is really different than what our people saw in New York City, the ones that went to support New York City and the Navajo Nation.
Yeah, yeah.
Can you, I mean, we've all seen these things in our news. And I don't know, it's not the topic of today, but can you put in 1 or 2 sentences on what happened in New York?
So the people that we sent to New York reported back devastating picture of hospitals overwhelmed. Whereas our hospitals maximum, each hospital has had maximum 50 to 60 patients with COVID at a time. They were in hospitals in New York that were having 700 patients with COVID at one time, with intensive care units set up in the cafeteria, set up in every ward. They were using every available space. And the mortality rate for individuals on ventilators approached 80% in one hospital. It was shocking. We have made our presentation to the Board of Regents of California last week, and it is online. And 2 of our doctors talked about their experience, one in New York City and one on the Navajo Nation. And for me, as a new leader coming into a very large and effective health system, my concern was that we not enter a period of crisis care, and that we do everything we can to prevent going into crisis care. And that literally kept me up night and day in January and February. And we've come together. They're excellent people. And I feel like we have a system that's working. And I hope that others across the United States can do similar things, because what I believe you see from the UC system is that if you can avoid overwhelming the system, you can have good outcomes for patients with COVID-19. Even our patients on ECMO are recovering and going home. Yeah.
Same with us.
Carrie, do you think that the density of the population in New York City in particular was a factor in this? I haven't seen a lot about that, actually.
I think there were a number of factors, and there have been some publications. Clearly, the density in New York City exceeds the density that we have in any of the cities in California. But I also believe when you have a new illness, and exponential growth is what you can expect because everyone is non-immune, every single day makes a difference. And the governor of California issued shelter-in-place orders at least 1 week before New York, and that 1 week makes a big difference. And here in the Bay Area, we were under shelter-in-place orders even earlier than California. So I left my office on March the 12th And the governor of California issued shelter-in-place order on March the 16th. And then March the 19th March the 16th was for the entire Bay Area, and then March the 19th for all of the state of California. We believe that those orders saved lives and really changed the epidemic trajectory in California.
Yeah.
May I ask you a question? If you are looking at the so-called preparedness index, which has been published last year, it's quite interesting to see that you have nearly an inverse relationship between the favorable outcome from position 1, United States, and position 2, United Kingdom, and the actual death toll there. So apparently there seems to be something wrong with the preparedness index, and or at least it does not cover what is really relevant in these terms. And therefore I think this will at the end be a very important discussion. So the second aspect in this regard is, of course, that how to prepare is not so much a matter of what has been written down 10 years ago in some pandemic crisis plan nobody ever will look at. But it is much more the question, what will you do actually and who is doing what actually? And our experience here is at least that you should not too much rely on what the government does, because governments usually talk with governments and they usually talk with clerks, but they don't know what is happening in the healthcare system. So I was quite interested in what I heard from the Charité, because that is closely similar to what we did. So actually, we decided to build up a hospital in the hospital, and we did this within 3 days, although nobody thought about that. And we completely centralized the care for these patients over the whole state with many, many other dashboards and so on. We probably will discuss that later on. But I think a very important question is, there are two aspects which seem to be important for how you manage this crisis. So the first one is, how definitive and how quick is the response of the government in terms of shutdown? We saw that we had a 6-fold increase within nearly 1 week in the patients hospitalized to this COVID house. And we saw a 4-fold increase in the intensive care unit. And within 14 days, 50% of all the intensive care unit beds, which are closely similar in terms of per 100,000 in Germany, were filled up. I mean, there is a difference between the ICU beds you probably have available, or let's say the ventilators you have available, and the equipped personnel which is capable of doing adequate ventilation.
That's
and
the
there's
issue.
an enormous difference in between. And as much as I've heard from New York, for example, the problem was not so much the fact that they were suffering while lacking ventilators, but apparently many people were involved in ventilating patients who had no experience in doing that.
Exactly
So
right.
we, for example, educated more than 1,000 nurses in a province with, let's say, an area of 750,000 people in order to prepare it. And we did this within 1 week or 2 weeks. But if you break it down to what we actually would have been possible to do, then we had achieved 50% of what would in reality have been possible. And this in a country which was in no comparison, no comparable degree struck by this disease as many, many other countries. So personally, I think every day a decision is lacking is extremely important. Therefore, the question, for example, will rise. I don't want to interrupt all the others, but for example, in advance, there was no idea from any international society or from any government or communication of one government with the other, which would be an ideal hospital structure to care for these patients. So 2 months after we did this centralized structure, the Robert Koch Institute published an ideal management, which is closely similar to what we heard from the Charité and what we decided to do here. But nobody ever had discussed that. So there are many areas, also in Austria, where there's a very much decentralized nature of caring for these patients, leading to a breakdown in the staff and of course to inadequate care of the patients. So I think there's a systemic unpreparedness on the one hand, the preparedness index apparently does not reflect what is really important to do. So for example, from as much as I remember from Munich, I saw a report which is closely similar to the experience we made. So one very important aspect for me seems to be that you have to build up a complete different decision structure. So you must go away from how a hospital is usually regulating by its medical director and so on, all the things. You need for a short period of time, particularly if it has to occur extremely quickly within days, people who can do that, who have the experience and who are decisive enough. And they must have direct access to the government and to all other decisive structures. So if you remain within the usual structure, which is well equipped and well, let's say, well operating all over the time, you are completely out of the decision structures and speeds which are necessary to keep up with what is necessary. So that at least is a part of the experience we have made here. But I think it will be extremely important to find out what in this regard has been made in experience in all the other centers.
I agree with you so much. We could not have run in the same way and have been as successful. And we started very early. From literally January 1st, we began. And one of the advantages that I saw in the state of California was my access to the governor of California. And we were able to work with public health and the governor to help inform the decision-making that was happening. And the University of California health system is the largest health system in the state. And so we could organize in an aligned way, and it made a very big difference. That fragmentation across the United States, I think that is what limits the reliability of the preparedness index.
Can I make one comment, Stephen? Because it was this interesting experience from Austria. What completely kind of failed in this crisis was Europe. I mean, that was unbelievable. The borders were closed within a couple of days. There were restrictions in transferring medical equipment, for example, from Germany to Italy. It was an unbelievable status. We had a couple of patients from France at Charité, and we treated them well, and most of them could be sent home afterwards. But overall, the response of Europe to that crisis was something which is that was really bad. And there are now many discussions going on. I was in one this morning, how to improve that next time. But that was one has to say, was a complete failure from my point of view.
I think this is one very important aspect. I'm quite sure that there was some communication, as I already said initially, between politicians and ministers, but that is without any meaning. So for the reality which is taking place in such a situation, it would be necessary that the crisis teams and the physicians, the leading physicians within the crisis teams, get into close contact and discuss how are they prepared, what are they doing in order to get control of the situation. And personally, I think that hasn't happened at any point of time. So that would be the most important aspect, but because apparently some of the institutions took independently from each other the decisions which very few persons thought was necessary to do, but it was not systematically applied. So for example, we used also a convention center. Within 1 week, we tried to get 1,000 beds in a convention center because retrospectively, if the close down would have been, let's say, 7 days later, we would have needed with 1,000 beds in addition. And later on, I found out that some other centers in the world, in the US, also in Austria and Vienna and so on, took the same decision. But surprisingly enough, there was no institution which ever made, let's say, a calculation for how many beds of which type you would need in which period of time which type of equipment you would need. And if you see the first patient come in Europe, that was at the beginning of January, as much as I see. And the last sentence I would like to say is the following: you are very lucky that you could start in your preparation in California in January, but I can say that in my province, up to 14th of March, nobody did anything. So that I got personally a crisis and said, okay, then it is necessary to take over, because otherwise this will be an enormous crisis. So personally, I really think that the handling, the operating and deciding physicians should those who should responsibly talk with each other in a very, very close network. And there's no infrastructure for that. I haven't seen it, even in a small country like Austria with 8 million inhabitants.
Yeah, thank you. Albert, you had a comment?
Yeah, I think in the Netherlands, it went a little bit better because the government was very clear and operated in now collaboration with the experts. And they give many messages to all the people in the Netherlands. I think the university centers worked very closely together, and they shared experiences like that convention center Richard mentioned. So that was done through the whole country, these kind of actions. I think what difficult was for many people that many experts disagreed. As we know, it's almost a definition of an expert, but for the people and the layperson, that was very unacceptable, in fact. And the journals, of course, used these disagreements to write long papers, but it didn't help us really. Because I think, as we say by joke, often say, normally everybody knows everything from football, from soccer, and now everybody knows everything from COVID, which can't be true because it's a new disease. But I think also as scientists, we have to think and discuss that in such a crisis, maybe you should have your academic discussions not in journals. The other interesting thing was that the way people collaborate was fantastic, and more. Also, many people who left nursing, for example, came back and were trained. So the collaboration was fantastic. And I think we have an interesting ethical discussion because we have, I think, almost 25% of the beds Germany has in comparison, IC beds. And we have an interesting ethical discussion, who should go to the ICU. And as you probably all know, we have a good system of general practitioners. And there are many patients that are not even sent to the hospital because the chance that they will make it was so low. So that is, I think, also an important debate for the future and to learn more about. Because having been a long time on an ICU is also not that healthy and good for your mental status and so on. So I think that's also an important debate. Thank you.
Yeah, thank you, Albert. In a minute, we'll talk a little more about the financial impact of COVID. I noticed a few people have joined since we did the first round of introductions, so I wanted to just give those individuals a chance to introduce themselves and to welcome them. Massimo, you want to say a few words about yourself?
Thank you, Steve. Apologize, I came a little bit late. My name is Massimo Pignatelli. I'm the Vice President for Medicine at Nazarbayev University in Nur Sultan city in Kazakhstan, in Central Asia. We have obviously a very different system and different challenges compared to Holland or Netherlands or California or Austria, because we have a health system which is in transition. And I have to say that we did pretty well until recently. You know, we had our first case of COVID in the middle of March, probably about 11th or 12th of March. And then as we had the complete lockdown worked very well because we were able to contain the infection extremely well. We were able to keep patients away from hospitals. The government actually was very proactive because they built a new hospital, a new medical block. There was a dedicated COVID hospital identified. So it all went very well until the 11th of May, when the state of emergency was lifted. And I have to say, in the last 2 or 3 weeks, it's a little bit of a shift, a real nightmare now, because now our hospitals they have a 90% occupancy. Our emergency services are really overwhelmed. Our testing labs are also overwhelmed in terms of accepting requests as well as delivering report. And there's really been a dramatic shift really in the last 2 or 3 weeks. So we are in the middle of a crisis, in fact, because we need to increase our testing capacity. We need to increase the number of beds available for COVID patients. We need to strengthen our emergency services. And our hospitals in the medical center, they're not COVID hospital. But we may need to now to repurpose at least one of them. And we are just in the middle of this discussion. So we were doing well, but then suddenly everything changed. And so now we are really in the middle of this, in managing this crisis.
Yeah, thank you, Massimo. Jadranka, can you hear me? I hope I'm pronouncing your name properly. Jadranka joined us from Ljubljana, Slovenia.
I can hear you. And
yeah. You want to introduce yourself, Jadranka, and please correct the way I'm pronouncing your name.
It's as I see, my face is not seen clearly. However, it's something. My name is Jadranka Buturović-Ponikvar. I'm nephrologist by training, and I'm professor of medicine. And I now am the medical director of the University Medical Center Ljubljana. This is the largest hospital in Slovenia and also biggest in the region. And it has more than 8,000 employees. And we were also the central COVID hospital during the crisis. And as concerns crisis, we went through it better than we have expected. At the beginning, in the mid of the March, we are located near Italy and also near Bergamo. And when it started, we were horrified that we will something like in Bergamo will happen to us. However, luckily it did not happen. We reduced our elective activity, and we have a larger clinic for infectious disease, and dedicated the majority of our ICU beds for the prospect COVID patients, but we never filled all the capacities. And it turned out that at the top we have 16 COVID patients in ICU and 52 in the hospital. And in this period, we were able also to preserve complete transplant program in our hospital, even more intense than in peaceful times, because many centers in Eurotransplant, Slovenia is a member of Eurotransplant for 20 years, and up to 45 centers in Eurotransplant were closed during the peak of the crisis. We couldn't afford that to Slovenia because we are only transplant centers. And so there were a relatively high number of high quality organs available for Slovenia at that time. So we performed more transplants, hearts, lungs, livers, and kidneys than in the peaceful time. So there was also some, for our patients, it was some benefit from this crisis. And after in May, this crisis went down, and we are now going towards our normal activity. However, as you are probably aware, there is again the concern of the second wave, of prolongation of this first wave, and we are not sure what will happen. We have many employees and patients who visit ex-Yugoslavia countries like Bosnia and Herzegovina, Serbia, and there is a Northern Macedonia, Kosovo, and there, and actually we have import now of COVID cases from these countries. We were in complete lockdown for 2 months, and it's hard for the people also to live in such a way. And at the moment, the situation is good, but it's not stable.
Yeah, thank you, Jadranka. I appreciate that perspective from Ljubljana. All right, let's see, Nicholas Andre from Aix-Marseille. Good day, and can you introduce yourself to the group? And
yes,
please.
sure. Can you?
You just muted yourself.
Oh, sorry. So is it okay now?
Yes.
Okay. So sorry, I could only join in a bit too late because of some other duties. So my name is Nicolas André. I'm professor in pediatric oncology. I'm also in charge of the adults and children early phase clinical trial program here. I also have a research unit in pharmacology and oncology, and I'm also the vice deputy for health at Aix-Marseille University. So I wouldn't be able to talk for the whole France, but there were clearly different situations depending on where the COVID wave were hitting you. So here in the south of France, in Marseille, I guess the wave hit us like 2 to 3 weeks after the eastern France and Paris. So we basically were fully aware of what was going on, and we had time to organize. So I guess the first one, as you know, Didier Raoult is in Marseille. So I guess to some extent it impacted on the way we apprehended the wave, the pandemic. So the first point of the strategy was to test as much as we could patients who had symptoms, and then test the family or the relatives around them and at least isolate them. So I won't go into the controversial issue of treating them with chloroquine and the antibiotics. But like the first thing is that we were able to test much more than anywhere else in France. I guess it contributed to make a little difference. Then, so we had like partnership really with the different team labs in Aix-Marseille University to try to, share the equipment to be able to make more tests, or use the 3D printers to make the mask and everything. Then the second point is that the hospital had time to fully reorganize. So basically all the intensive care units were turned into intensive care unit for COVID, including pediatric intensive care unit. Most of the medicine department were turned into COVID units. The pediatric hospital was more or less not close, but like really, we just like balance the patient who needed care or would not need care versus the risk of COVID. And at the end of the day, the hospital was not overwhelmed by the pandemic. Like the hospital was like 100% full with patients, but we could handle it pretty well. And so I guess, as some of you said previously, you have to slightly think out of the box to find the right solution for something that we had never met and we didn't know how to cope with. But it was easier for us as we could benefit from the experience from other countries and other cities in France. I guess that's, then we're pretty much out of it now, which is like 2 or 3 new COVID patients per day in Marseille. and like the hospital is pretty much now going back to normal, especially social distancing measures.
All right, thank you, Nicholas, and welcome. The next item on the agenda that we want to just spend a few minutes on is the financial impact of COVID-19. And as you know, it varies around the world somewhat with how health is paid for in a country, how education is paid for in a country, and that can be very different in different places in the world. In the United States, major academic health centers are losing somewhere between $2 million a day and $15 million a day because of the way healthcare and education is funded in the United States. Like I said, different places. The association, AAHC, has been active in the US, advocating for some of the relief funding packages for healthcare in the US. But we thought we would just go around and maybe just hear 1 minute or so from each person, if you have something to share, about the financial situation as it relates to COVID in your area. Hayo, you want to say a couple of words about that?
Well, I can do that. We are a state-driven place, and so the state told us to have this partial shutdown, and for compensation, they gave us per empty bed per day, or not used bed per day, 580 euro. The costs of that in Charité are around something like 880, so we had a total of more than 300 euro per day losses, and we had something like 500 to 600 beds open per day. So at the end, without the aspects of equipment and other things, we have something like currently something like a deficit of about 70 million euro out of these 2.5 months. And there's an intense discussion of who pays for that, because as I said, we're state-driven. We are run by the state of Berlin, and the state of Berlin would like the federal government to compensate for these losses. So it's under discussion, and it's a big issue currently throughout the academic medical centers in our country.
Yeah, thank you. Jadranka, Slovenia has one of the more socialized systems of medicine, at least as I understand it. You want to comment briefly on the financial impact there?
Yes, Slovenia is pretty social, and it is almost predominantly public healthcare system. And our hospital has a year budget from 2011 about 560 million euros, and we expected to have a balance. We plan to have a balance on 0 this year, but actually 1 to 5 months we are more than 20 euros in deficit. And this is not only the program and services we have not realized. Our public state insurance company has a plan to reimburse us 80% of the non-realized services, but this income is not realized. It's only at the level of promise. And we also have a lot of storages, a lot of reserved drugs and other things necessary for the hospital. Actually, we have during normal function, we have a reserve for 2 weeks. We now have for several months because of the lockdown of the crisis. So we will see how we can use it in the several months if situation turned out to be stable, but we are not sure if it would remain stable, and our only option is to adapt month by month or day by day.
All right, thank you. Richard, what's happening in Salzburg?
Yeah, this is a general hospital, and we have a slightly different payment system as compared to Germany, because we have a system where all the deficits of the hospital have to be covered by the state or by the province of Salzburg. So everything which is done within the hospital, any type of surgery, any type of chemotherapy, per se is underfinanced. So you cannot have a successful and economically successful hospital in Austria by definition if you are a central hospital. So this is within the system. This means that the deficits, which are of course the result of sparing many types of surgery and other types, that is in the range of, let's say, 50 million euro or something like that, which is the complete deficit for a hospital with 1,300 beds. This will have to be covered by the government of Salzburg, and we have to see that that in Austria the lockdown is by the federal government is only a recommendation. So how to handle a recommendation, which is not a law by itself, but only, as the term says, a recommendation. So there will be negotiations between the provinces and the federal government. But at the very end, the taxpayer will have to pay for it.
All right, Albert.
Yeah, the hospital expects around 60 million deficit. University also a huge amount. But the issue is that in the Netherlands, the academic hospitals and universities are rather rich. So of course we have these discussions, but the chance that the government will pay us is very small, I guess. So we have to solve it ourselves.
All right, thank you. Massimo, what's happening in Kazakhstan?
This is, we had to, with the lockdown, obviously we had to reduce all our clinical activities in the hospital. We had to put our staff on minimum salary, on leave, on someone on unpaid leave, really to reduce our cost. So over the last few weeks, we've actually restarted all our operation, which has actually been now is associated with an increase in, because there is increase in mobility, and with the easing of the lockdown, also an increase in number of cases. But having said that, we've actually now started to increase our revenue and our activity. I mean, our system is very different from any other system that we're discussing today, because I think the health system is really underfunded in Kazakhstan, and in our academic medical center, actually the university is actually supporting the medical center. And so, for example, just last week, we were actually, the university has actually approved some bonuses for all the clinical staff in the hospital. And so that really to cover this lockdown and the reduce of income. And this would be paid by the university, which is probably a little bit unique, I have to say. So, so we are supporting, the university is actually supporting our academic medical center in this difficult time.
Thank you. Nicholas, you have anything to add from the south of France?
Can you hear me now?
Yes.
Well, no, well, I guess in French that the whole hospital belongs to the public system. So to some extent, I mean, it does not really matter how much money you lose, it's going to be covered to some extent. And I'm not able to tell you right now what is the financial, weight or loss that the COVID has induced in our institution. Because like the hospital was full, but like all the regular activities, all the surgery department were closed. So I don't really know yet how it's going to be handled and solved.
All right, thank you. Interesting. Carrie, you want to talk about the UC system?
I'm happy to, and a little bit horrified to share the numbers compared with other countries. They are a public record and shared with the University of California Board of Regents on Wednesday of last week. So between March 15th and May 31st, I am reporting a $1 billion loss to the University of California system across the 12 hospitals. 800 million of that is in lost revenue from the shutdown, and 200 million in extraordinary expenses, including the purchase of PPE. The supply chain breakdown for personal protective equipment resulted in enormous expenditures for PPE across our system. And other expenditures related to laboratory test development, construction of new beds. We brought on 1,500 new beds across the system and in personnel. So it is a remarkable number. We have received to date about 500 million from the federal government through the CARES Act. So about half of the losses have been recouped. We will be submitting our request to FEMA, the Federal Emergency Management Act. We hope to recoup another 200 million from FEMA. It still leaves a significant gap of about $300 million. We are self-funded, even though we are a state public institution. We are self-funded through clinical income. So I will be convening a strategic planning session in July to address the recovery from COVID. And we hope to really bring to bear some of the things that we have learned and the new resources that we have built, including our telehealth network, to generate new types of revenue and new revenue streams to support our operations. The numbers are big, though.
Yes, yes, thank you. Rick.
All right, thanks, Steve. So Carrie runs a system of 12 hospitals. I run one of essentially one, but the numbers to scale are pretty similar. So we, again, while it's a state medical school, we have to pay for ourselves essentially. And we lose about $2 million a day in March, April, and May. So there's $25 million per month. So a $75 million deficit, or 1/3 of our volume for one healthcare system. So in order to manage that, and I'd be interested in what they did in California, we started a number of financial cuts. Sounds like they did this in Kazakhstan too. So immediately, all of our executive leaders that made over a certain amount of dollars took a 10% decrease in salary for 3 months. And after we did that, then we started doing furloughs. So everyone in the healthcare system has to take at least one furlough week within that 3-month system, or a 10% decrease in pay. We eliminated about 350 vacant positions. And we stopped a lot of agency contracts to save money. So we took a lot of cost-cutting measures. And then our single hospital got $25 million from the federal government from the CARES Act. So we're still digging out from this. We stopped capital plans to do renovations to some of our hospital buildings, a $50 million plan. So, and then we do get some money from the state, and we lost $3 million from the state. The state pays us, when the state budget goes down because of decreased tax, sales tax revenue, then everything that they can fund goes down. So the state of Missouri hit us with a $3 million loss for those 2.5 months.
Yeah, thank you. Sobering all around, but all right, let's see. Before we go on to the last session here, anybody, I think I hit every area, country, region that's represented, but if anybody else has a comment, I wanted to give them a chance to do that. Carrie?
I was going to say, just like St. Louis, we have done major changes. So we have no travel allowed at all right now, and probably for the next year, we will not be traveling. We are in a hiring freeze, so no new hires and no merit-based salary increases are allowed. We did make a commitment to have no layoffs related to COVID-19 through June 30th. That's with our unions, and so we're working there. After, I think we will have to take additional efficiencies. And then I think the biggest change that we're seeing is a commitment to long-term telework. And our system leases a large number of buildings and space, and in a cost-saving effort, many of us will be working from home for the extended future. So that's going to be a real interesting change from in the post-pandemic world. The last day that I will have my office is July the 10th, and the soonest I will have office space again is a year from July. So that's going to be quite interesting to see how that works.
Yeah, wow. Yeah, interesting how things are evolving. All right. Any other comments before we go to the last session? All right, the last session answers the question, okay, what do we do now? You know, how academic health center leaders are planning for 2021. And Carrie, you got at some of that already. Albert, you want to make some comments about that?
And Stephen,
Yes.
I have to leave in 15 minutes, okay?
Thank you.
Thank you for having me here, but in 15 minutes I have to leave. It was very interesting. Thanks.
Yeah, thank you for taking the time, Hayo, to be with us.
Yeah, thank you, Stephen. I think as a university, as a hospital, we are now in the process of starting up again, like many others, of course. In the hospital, we are a little bit afraid when thinking about the future, that during the pandemic, many people who you would expect to go to a doctor with things like a stroke or a heart disease didn't went to the doctor. So we are a little bit worried. What does that mean for the long term? Will these patients come later or whatever? Nobody knows the explanation, but it's a bit worrisome. Still, we have all kind of measures to have the social distance and all these kind of things, like also in many countries. We had a huge discussion about education in the next year. So most of the education went immediately digital, but we decided as a university that we not go completely digital. Like some universities, for example, Leiden University decided to do that. We think that if possible, that we will organize contacts, because we think also for the students, social contacts are very important. You can do many things on distance, but also many things you can do on distance. So now, step by step, the board of university and the board of the hospital each week we make new plans and follow up. For example, we now allowed the third-year medical students to practice in the skills lab because they need to do an exam, and you can't simulate some things in the skills lab, but not everything. So this process is really step by step and very carefully. What is interesting for me is that how long will people listen to all recommendations? Till now, people in the Netherlands listened rather good, not always, but most of the time good. But I think there will be a moment, because people are social people, social human beings, that it will be very difficult to that people listen to everything that the government is saying. So that's the biggest worry. We think we spend a lot of time in taking care of students, because for some of them it was not that difficult because they went to their parents. Some of them were alone because they couldn't go back to their countries, for example. So that is also the mental process of the pandemic is, we believe, also a very important process that we should take care of for students, but also of people. For example, most of the research staff did it very well, but some of the lab technicians found it very difficult to be at home because they couldn't do anything there. So there, I think we also, as leaders, we have to take care of all these kind of people with their different needs and worries. I think this is in a nutshell, very shortly.
All right, thank you, Albert. And I think last on the agenda, Rick, you were going to give us some comments about thinking about the future.
Right. Can you put up my slides? I guess I did have a little bit of background too, like Harry did, but I will talk about the future as well. So I'm going to give you a somewhat different perspective, because our perspective in the middle of the United States, you can go to the next slide, is that we were not hit hard by COVID. If you look at the numbers, our local impact in the middle of Missouri, and we're right in the middle between St. Louis and Kansas City, was 276 positive cases, only 3 deaths at our hospital. So I know it's just, the scale is much less than all of you are describing. And just in the whole state of Missouri, there were just 880 deaths. So nevertheless, even though the direct impact from the COVID virus on affected cases and deaths was not large, the impact on our healthcare system and our School of Medicine was huge, just because you had to respond as if you were going to be in the worst case scenario. So next slide. So like everyone, we had to have drive-through COVID testing centers and come up with a variety of ways in order to keep our staff and our students and our faculty safe, and so we did. Next slide. The medical students in the first and second year, in the United States, it's different from the European model. So there's 4 years of medical school after college. And so the ones that were in their preclinical years, they basically all went home, and they had to do all video teleconferencing, and they took their exams online. Next slide. And then the students in their clerkship years, they had to go home as well. Now, once we got telehealth ramped up, and I'll talk about that in a minute, many of the students were able to participate with the faculty on the outpatient telehealth visits. But we had to create virtual rounds, we had to exclude. This is really more of an issue of safety, and we didn't have enough PPE for the students, and so that's the real reason that they couldn't come into the hospital and into the OR. Next slide. So now, as we're moving into the future and into the fall semester, and we believe that we're going to have a hybrid of face-to-face visits. The students are back now on the hospital wards and in the clinics, but still they are not we do not allow the students to go in any procedures or in any of the ORs, and it's because we don't have enough PPE. That's the reason. And so that's what we're operating on, and that's what we're going to continue to operate under. Next slide. The research, as in all of your universities, even though we did not have that many COVID cases, we had to stop essentially almost all research. We did allow patients that were in active clinical trials on drugs and devices to come in further study visits wearing PPE. But basically, all new patient enrollment on site was shut down. Missouri is called the Show Me State, and so now we're in the Show Me renewal phase, and we have a 6-phase system in order to reopen our animal and our human research, and we're now currently in phase 3, and we should be back to running to normal in a couple of months, I think. Next slide. So we did have to adapt, as I'm sure all of you did, and the wet labs that had to stay open for various reasons, we had people working shifts. On the clinical side, I'm still running some clinical research studies. I have an amyotrophic lateral sclerosis clinical trial. So we changed the protocol to do it all remotely. So as long as the patient had at least one visit in the clinic before, we changed the criteria so that you can enroll patients remotely. And fortunately, on some, if you could assess patient assessment over the telephone, over telehealth, then we sent them their medications by mail. And so we were able to continue my study without having any drop in enrollment, but it did take some flexibility by the IRBs to do this. Next slide. I already mentioned the finances, so I won't go over this again, but basically it was about $6 million a week, about $1 million a day, $75 million loss. And we, I think we are actually going to be able to bounce back out of this quicker than the California system because we're able to ramp up more quickly back into clinical care. Next slide. The telehealth, at University of Missouri did 0 telehealth before the pandemic, 0, which surprised me because I came from Kansas right before this, and I was doing a telehealth clinic in rural Kansas for ALS patients, and I did 240 visits a year, but they did 0. So we were up to 4,000 a week, which if you look at the scale with Carrie's 12 hospital systems, it's not that far off. So this really has changed how we're going to practice medicine into the future. As Albert talked about, and I'd be interested to hear about the European telehealth experience and what they plan to do in the future. Next slide. This is just, again, our numbers, because when we had to shut the hospital down, except for anything except emergencies and COVID, so our census went way down. Now it's coming back up, but still about half normal, interestingly. Our OR cases, which actually essentially had to stop, except for emergencies, we're now almost back to normal in OR cases. And our clinics also are almost back to normal. But again, this is a combination of telehealth and inpatient visits. Next slide. So this is my last slide. So I think because of this exercise, tragic as it is, we interestingly were able to make some significant gains in how we operate as a healthcare system and as a medical school. And we think actually we were able to make some efficiencies that were forced on us by COVID. Some of the things we were actually thinking about doing here before, but then when COVID hit, we were able to do it very quickly. And as our volumes returned, with an aggressive 2021 budget, taking COVID into account, we think here in the middle of Missouri that we're probably going to be okay. And that's what I had to say, Steve.
Yeah, thanks, Rick. Comments, questions?
I wanted to hear about telehealth from Europe, but
Yeah.
Albert, you raised your hand.
Yeah, I think we didn't do that very often, indeed. But I think many people learned that you can do many things without that the patients come to the hospital. And I hope seriously that we will stay on doing that, because it's a big advantage. People don't need to travel. Older people traveling is not that easy, or relatives had to organize it. So I think that attention for telehealth, I hope seriously that we will keep on doing that, because it saves a lot of time for as well patients as well doctors. Of course, not all consults can be done on telehealth, but many can. And I also think that, and we have that discussions already, that we also should realize that the strong things we learned in the pandemic, that we keep on doing that. Probably it will not be that easy, because we are all human beings and we have the tendency to go back to the old days. But I think the leadership is very important, that we keep on doing what we learned. And because we can gain a lot, and I agree with you that you mentioned that. So I don't know.
I'm sorry, go ahead, Albert.
No, I don't know how Hayo sees it, because he's still there. Telehealth in Europe.
Yeah.
What was that?
Telehealth.
Comments about telehealth in Europe.
What?
Comments. Rick was asking about the status of telehealth, the use of telehealth in Europe.
Kind of exploded with COVID. I mean, we didn't have very much before. We have a specific German thing, which is we call that academic outpatient services, which is a unique opportunity for academic medical center to interact with special patient populations on an outpatient basis. This is usually in Germany very restricted. And from the start of of COVID-19, of course, the visits of these outpatients were quite limited. And so we switched all that to digital visits, and we have now something like 200 or so different topics in these outpatient visits, which are digitally covered. So there was a kind of a big, a big bang in terms of development of IT interaction with patients. We are pretty much in Germany, we're pretty much hampered by very, very high data protection standards. So it's difficult to get these things realized, but that has really worked out well. It's one of the positive experiences out of COVID-19.
It's amazing how all of our IT teams seem to overnight, when charged with this, pull off something. We all complain about our IT teams every day, and yet somehow they were able to pull this off almost across the world, and everyone adapted and did it. What I'm worried about in the United States, and this may be true even if you're socialized system, someone's got to pay the bills. And so in the United States, the government relaxed their compensation for digital telehealth so that we could get paid the same whether or not you saw the patient over telehealth or in person. And the fear is that they might go back to not compensating us very well. As long as they keep the compensation level up where it is now, I think it'll become a viable part of moving forward in our healthcare delivery.
Probably the greatest danger is that everything goes back to how it was previously.
Right.
The winners will be those who understand that this is an enormous chance for getting a leap forwards in digitalization, but also in many, many other aspects. So I think one of the most important aspects is that we even need much more research. So despite the fact that all the healthcare systems and the governments, of course, run into a significant debt, it is nevertheless clear that nothing is as expensive as COVID is. So the adequate care for COVID with a significant early lockdown is significantly cheaper than letting the pandemic run. And that makes clear that you need much, much more investment in healthcare. So apparently we all are running healthcare systems which are extremely efficiently. And this is something like the Achilles heel, which of course means that as soon as you need an add-on in terms of personnel, as well as in terms of, let's say, beds or anything else like that, it becomes extremely difficult and also extremely expensive. So I think there is the need for a more general debate for how to care for pandemia and have adequate reserve capacity, but still in an efficient and economically adequate manner. Then it is clear that we need immediate access to research, for example, and also to publication. So during, let's say, December 2019, up to March or something like that, the leading journals in the world were extremely reluctant in preparing you with adequate information. So this information was nearly exclusively covered, let's say, by CNN and by BBC, which had the best information, better information than the leading medical journals up to a very recent point of time. And the telemedicine, we introduced that dramatically. We called every patient by call, by telephone, not to appear in the hospital unless the patient would have previously had a call with us. So they shouldn't stay at home, of course, if they were sick, but they should inform us. And it turned out within a very short period of time that telemedicine is extremely efficient for many, many, many patients. So enormous investments for digitalization, which are not so much, let's say, advanced in Europe as they probably are in the United States, should occur in this situation. And in relation to my Dutch colleague, I would say, of course, you may be concerned about the fact that probably some patients did not appear apparently for myocardial infarction. But for example, in Austria, there is definitely no excess mortality, nothing in terms of that, despite the fact that in about 50% of all the surgeries were taken back. So this will lead to a certain discussion. Of course, you can now introduce and say, okay, so many patients were at risk because they did not appear. But that is a matter of communication with the community. And personally, I'm quite sure that in the long run, we will have a discussion about efficiency and effectiveness of what we are doing. So that is particularly the case in surgery. I would like to say, for example, in Austria and some hospitals in Germany, there is a 30 to 40%, let's say, usage of operation theaters a day. So, of course, that is probably much different to the United States, but you have to think about indications and particularly about efficiencies. And the COVID crisis has made clear that within days, you can become much, much more efficient, much more transparent, much more in communication with the surrounding, with the public and your patients. And I think we should take out what we can positively transfer and which shouldn't be forgotten.
Yeah, thank you. Very, very interesting perspectives. Any final comments or thoughts from anyone? Albert?
Yeah, maybe what was said in the beginning, that maybe we should start some of the sharing, how you organize yourself in such a pandemic, because I think apparently many people said, some of them said, well, we could learn from others because we were later, but many said it's remarkable that there's not more communication about how you should organize a hospital in such a crisis. And maybe that's something for our AAHCI to think about and bring some people together to write something about it and share it. Just an idea.
Yeah, would be a good idea.
I like that idea also. And, you know, early on, we were arranging conferences with colleagues in China to understand what they were doing, and with colleagues in Italy. I think clinicians on the ground, when they are dealing with a new infection, desperately want information from someone who's already taking care of a patient and what they're trying, what they're seeing. And then for me, the explosion of social media, never in my life have I gone to Twitter to find scientific information. And now I feel like it would have been impossible for me to navigate the pandemic without social media, finding the papers, learning about preprints, bioRxiv, medRxiv. I had never used those resources before. You have to spend extra time because they're not peer reviewed, but at least it's information.
Yeah. Very interesting. Very interesting. Any other comments? Well, this has been a very useful session. Paul Stewart, who is the professor and dean at Leeds in the UK, was not able to join us, but he wrote a piece about the financial impact there, which I think is going to be published in our Leadership Perspectives International publication. And so we'll share that with you and follow up on Albert's idea. But thank you all. I know how busy you are, and thank you for spending time with us today. I've really gotten a lot out of hearing the breadth of perspectives, and always interesting to take a look at your computer screen and see people from so many places around the world. Really appreciate everybody being with us. Welcome to some of the new members, and look forward to engaging again soon. And if you have ideas or ways that the association could be helpful in bringing people together, like you were saying, Carrie, bringing folks together, we'd be delighted to work with you all on that. So thank you all for being here, and wish you a good day, whatever meal you're about to have. Wish you a good meal and a good day. So thanks for being with us.
Thank you.
Good evening.
Bye.